Good afternoon,
We
everyone.
we were telling creepy stories, ghost stories.
Ooh. Hmm.
Hmm.
I was always the cynic until we moved into our apartment before we bought our first house. And yeah, there's definitely something.
Hmm. For sure, for sure. So we're going to kick it off in just a minute, but we're going to talk about electrolytes just briefly. I posted something on Blackboard, and it shows you the difference between an EEG or EKG when you have not enough potassium, hypokalemia, and then also hyperkalemia. So it's really quite interesting. Sodium not so much affects EKG, whether it's low or high, not so much. Um, However, magnesium and calcium do somewhat the same. Calcium, you get similar uh, elevated calcium, excuse me, elevated magnesium, you get a prolonged PR wave, which is relatively similar to too much potassium. And then calcium is kind of the same with a, ST elevation. It's not so much peaked, but it's also a prominent U wave. So the three of those are somewhat similar, but it's just very interesting what hypokalemia and hyperkalemia will do to the EKG. So, speaking of calcium, what does it look like if you have too much? What does your patient look like? First of all, what affects calcium to give it too much? An overactive thyroid will drive up your calcium. Steroids will drive up your calcium, or excuse me, um, what, and then things that bring calcium down, kidney stones, absolutely, they will. They will, absolutely. What brings it down? Prednisone can bring down your calcium. IV fluids and diuretics can bring down your calcium. Calcitonin can drop your calcium. So a normal calcium is anywhere from 8.5 to 10.2. So a lot of these values, a lot of these normal values are a tiny bit fluid because it's a lab reference range, and some labs will have 8.6 to 10.3, and some labs will have lab values, norms will be like 8.4 to 10.3 or 10.1. So it's not, it's somewhat fluid, but then it gives you a um, generalized reference range. So what about magnesium? What's the normal for magnesium? Does anybody know? It has a little more narrow, 1.3 to 2.2, really. Yep, there you go. Thank you, Alice. So, um, yeah, and see, there you go. I mean, it's like, it'll be 1.3, 1.2, they're pretty synonymous with a range. And that's why they're called reference ranges. So everybody knows what potassium is, right? Yep. And I've seen labs have 5.2, 3.5 to 5.2, but then, that's kind of superfluous. Certainly it's a range. And then of course sodium is what? Absolutely, absolutely. So something about sodium, what happens when you have, what are the side effects of too much sodium? Remember, wherever salt goes, water goes. So if you have a lot of sodium, you're also going to retain a lot of fluid. Yep, absolutely. Confusion, seizures, fluid overload, seizure, neurological changes up to seizures, unconsciousness as well. And interestingly enough, too little sodium can cause coma as well. Typically speaking, though, on the low side, you'll have nausea and vomiting as well. So those are just some brief kind of topic discussions. Um, your whole life as a nurse, you will, and certainly in your other courses as well, when you're going reading history and physicals on the floor, someone will be recording H&P and they'll throw out some lab values. And as a rule, by the time you look at them long enough, certainly by the time you get out of school, you'll have the opportunity to learn them, and they'll become second nature to you. It'll become part of your nursing vocabulary. So anyway, so about as far as acid-base balance. So if somebody's in ketoacidosis, they're what? If somebody has ketoacidosis, what is their pH going to be? Low, absolutely, absolutely. So basically, they're acidic. So what is something that you can do that we do all the time in the hospital? What can we give our patient that's acidotic to buffer the acidosis? Absolutely, bicarbonate. And so in talking about, bicarbonate is incidentally one of the things we'll also give at at, uh, during CPR, right? Because when somebody's not perfusing, they'll definitely become acidotic. So we're going to start pushing the bicarbonate. It'll be part of that those life-saving measures. And so, bicarbonate is one of the things that you watch out for. And certainly when we're given electrolytes like sodium and potassium, we do give potassium infusions, right? And we talked about the safe rate for potassium. Usually, we typically don't push potassium because it'll do what? Boom, stop the heart. It will kill you. Right, it will kill you. So we don't push it, but there's a safe reference range in an infusion. And it's typically about what? Does anybody know? 10 to 20, what? Milliequivalents per hour. Absolutely. Absolutely, for sure. And, what is it about potassium that we must do when we're looking at infusions? What's a good nursing assessment on your patient receiving potassium? Monitor the site. Absolutely. Absolutely. For sure. For sure. Yeah. Check heart rate, EEG, EKG. Absolutely. Absolutely. In a lot of the situations, not only in this course and your exams, certainly, but in real life, when your patient is receiving any sort of supplement that has a propensity to cause antiarrhythmias or dysrhythmias, you're always going to make sure, especially on your NCLEX, right? The interesting thing to know about your NCLEX is you're treating a patient, but the patient is in words on your screen. So you're not going to get to visually look at that patient. You have to treat the patient on your computer. So that's when a lot of these critical thinking measures come into place, so that you can get used to, making those clinical judgments based on a set of facts or assessments or criteria. So that's something to think about going forward. Magnesium, certainly, you'll come in contact with magnesium and OB. Have y'all talked about magnesium and OB yet? No? Okay, not yet. Um, mag sulfate is something that you're going to give to women who are. Yes, yes, absolutely, Alice. The mag sulfate is something that you give your patient because it does relax the uterus. And why would you give it to? Why would you want to relax the uterus? What's going on that you want to relax the uterus? To stop the contractions, absolutely. So sometimes whether you are preterm labor, absolutely. So when you're giving magnesium, what is something you always want to watch for? And you'll find out is when you get to OB as well. You want to watch out for their deep DTRs, absolutely, absolutely, because it'll take your DTRs out. It'll make your muscles flaccid. And also, what else is a big muscle that you rely on for respiratory rate? Absolutely, bingo. Because if it takes, if it causes muscles to go flaccid, then it will also cause your respiratory response to be very flaccid and very non-responsive, for lack of a better word, for sure. All righty, we talked about the KCl, the potassium chloride. What about aspirin? So we didn't really talk about too much aspirin. We talked about aspirin. Actually, we did talk about this in Pharmacology 1. Uh, Too much, what we don't give it to kids for what reason? Rye syndrome. Absolutely. And then, interestingly enough, salicylic acid or aspirin can also affect your respiratory rate. So when someone has ingested, or when someone, particularly with an aspirin overdose, you always monitor for their respiratory rate. That's something else to be aware of, because what it does is it the if you remember anything about the Krebs cycle, what it does is it interrupts the Krebs cycle, and it causes um, it decreases the oxygen return, and it produces lactic acid. So what does lactic acid mean as far as the metabolic portion of your blood gases? It produces metabolic acidosis, which is where the lactic acid comes into play. And that's what happens when during overdose, aspirin overdose. It causes uh, dysfunction of the Krebs cycle and produces a lactic acid abundance in the serum. If I got that out correctly. So it stands to reason if your patient's low on potassium, what are you going to give them? Potassium. If someone is hypokalemic or hypocalcemic, they're low on calcium. You're going to give them calcium. The hypo parts of the equation of the minerals are a pretty easy fix. So someone has not enough magnesium. They're in premature labor, which is if their magnesium is low, that's going to put them at the threshold for that tetany, those muscle contractions, particularly if they're pregnant. So you give them magnesium. So anytime somebody is foundationally low in serum levels, it's to the lower limits of the threshold, then you always just do replacement therapy. That's the number one go-to, because it's easier to replace at low and modest levels than it is to bring them down from the high or upper ends of toxicity. Um, what are some things that correct too much potassium? What if you have too much potassium? What are you going to give? Too much potassium? Now, there's two times there's two times you're going to there's two things you're going to give for too much potassium. Kxalate, if you have time, because remember we talked about the potassium and the cardiac effects. So if you have marginal hyperkalemia and your patient's not doing too badly, then you're going to give Kxalate, because how does the Kxalate get the potassium out? Where does it go through? The stool, your gut, right? So the first pass effect kicks in, and it's certainly not a quick fix. It's a fix, just not a quick fix. But when your potassium is say, I don't know, 6.2, 6.5, you're going to want to do something really, really quickly. What are you going to give them? Well, you could give them Lasix, but calcium gluconate, absolutely, very good. That's what I was looking for, absolutely. Let's see, what else we can talk about. Um, so anytime your patient is, so let's look at a patient who's taken spironolactone. What is that? It is what kind? Absolutely, it's potassium sparing. So anytime you see your patient on spironolactone, you're going to always make sure they're not what? What's easy? What's low hanging fruit? Right. Are they taking potassium? Are they taking, do they have, are they on taking salt substitutes, right? So you're going to make sure that if something's going on, that they're not taking anything that could increase their potassium. So something else um, spironolactone is many times if your patient is also concurrently having heart trouble and they're in for congestive heart failure, they could also be on digoxin. So when anytime your patient is on digoxin and any other diuretic, one of the main things you're going to want to do is you're going to want to see what is, particularly if it's a potassium sparing diuretic. What's the first thing you're going to think about? Because what are you doing? You're wasting your you could be potentially drying them out, and then they're on a potassium sparing diuretic. Absolutely, you're going to get it. Well, you're going to certainly get an electrolyte panel. Absolutely, they could be having digitoxicity. So what's the first thing you're going to check, especially if they're on potassium? What are you going to hook them up to? EKG, absolutely. You're going to want to look their electrolytes, and you're going to want to check their EKG. You're going to want to see what's going on, because 9 times out of 10, that potassium is enhancing the digoxin. So you're going to want to see what the potassium is doing to their EKG. Plus, you're going to want to check their rhythm as well, because potassium causes digitoxicity. Now, one thing I'll just throw in there, there's a lot of drugs that affect digoxin, and we've talked about a couple of them so far, but we're going to review them as well. So let's see. We talked about mag sulfate. We talked about the fact that one of the things that particularly in OB patients, we look for deep tendon reflexes. And let's see. I guess that's about it. Does anybody have any questions on electrolytes or any of the content we just covered? So we talked a lot about congestive heart failure. A lot of your congestive heart failure patients um, will be taking beta blockers, and certainly they'll be taking something else. What else? What else would your congestive heart failure patients be taking? There's one particular go-to drug that probably 90% of your congestive Lasix, absolutely. About 90% of your congestive heart failures patients are going to be taking Lasix. Why would they take Lasix? Why would they take Lasix? What's special about Lasix? Yep. Yep, absolutely. And it's fast, Christian. It dumps fluid and it's fast. If your patient's in fluid volume overload, it dumps the fluid. So what is absolutely, Lauren, it does decrease the demand. So what does fluid volume overload look like? What is it? What is your patient edema? Let's see. Absolutely. Edema, crackles. Yep. What about right here? Pulmonary edema for sure. That's why you're going to listen to the lungs. JVD. Absolutely. That's awesome. That's awesome for sure. And the more your patient, they can come in, maybe they're even non-compliant, which is a lot of the case for sure. And they've had chronic hypertension and now they're in heart failure. So those are things to keep in, because your focused assessment for that's going to go straight to the lungs. You're going to assess straight for the lungs. Once again, spironolactone is, I've seen it used more and more lately. And certainly anytime that your patient is on spironolactone, I would not give it unless you check their potassium. I mean, um, that's just a very, that's a safety precaution for sure, for sure. So let's see, as far as spironolactone, we talked about some kind of quirky side effects. Do y'all remember which ones we talked about? It binds to, yep, it binds to the androgen it binds to the androgens in the patient. So, say for instance, men can get the gynecomastia, women can have the deepened voice. Of course, since I've been talking all day, it probably sounds like I'm on spironolactone, but I'm not. Um, and certainly any of the other hormone-related um, difficulties, whether it be menstrual irregularities, impotence, hirsutism like facial hair for women, um, and things like that. Let's see. So, what is it? We'll talk about some antihypertensives. So, what about ACEs? What's some interesting thing about ACEs? Why would we give ACEs to absolutely dry cough? Yeah, absolutely. And so, if your patient has a dry cough, 9 times out of 10, we're going to take them off that ACE inhibitor, right? Because the natural progression of it, if it's truly a problem, it could it can go into, yeah, switch to ARBs. That's what you usually do for sure. Angioedema, absolutely. And what could angioedema turn into? We'll talk about this particular syndrome the rest of this class. Airway problems, and they're more specific. It's a syndrome that we talk about more specifically. Stevens, yep. No, not necessarily blood clots, Jasper, but you never know. Yep, absolutely. Absolutely. And then something else about ACE inhibitors. So, why would you want your diabetic patient to take an ACE inhibitor? Right, for hypertension. Maybe so. I don't know. But what in specific? What does it protect? Kidneys. It protects the kidneys. Absolutely. Do you want your pregnant or your patient of childbearing years to take an ACE inhibitor? Absolutely not. Absolutely not. Um, let's see. And then somebody mentioned an ARB. So ARBs have their own um, uh, they can be bad actors as well. So while ACE inhibitors is a cough, so ARBs you have to watch out for something called renal artery stenosis. And so if your patient has had some renal artery stenosis, certainly that's where the main arteries in the that go into the kidneys become real stiff and hard. And certainly, somebody mentioned lipids earlier. You have high lipid counts for a very long time. You have smoking is something also connected with renal artery stenosis. But if your patient has renal artery stenosis, ARBs can exacerbate that, and actually they can become the kidneys can become insufficient as far as blood flow, and certainly it can cause much more severe renal artery insufficiency. So, renal artery stenosis is when those or stenosis is basically when those main vessels just become stiff, non-compliant. And anything that's stiff and non-compliant, it doesn't respond to blood pressure. You have sensors in all of your major vessels so that they can kind of help your system monitor blood flow. So if they're not able to contract and they're not able to dilate to help you adjust your blood pressure, then your kidneys can become very overwhelmed with either too large of a degree of blood flow or too small or too little of a degree of blood flow. So it really puts your kidneys in a bind. So that if your patient does have renal insufficiency, certainly an ARB is something that you won't want to give for sure. So let's see. We talked about when you're getting into a situation where you're at the bedside as a nurse. I mean, your patient's not just going to come in on one drug. They're going to come in on lots of them. They're going to come in on heart meds or hypertension meds. They're going to come in on diuretics. And so a lot of the times you're going to have to look at the symptoms and see what's going on. So always remember, go for the low hanging fruit first. So if somebody comes in and they're on they're on potassium sparing diuretics. The first thing you're going to do is make sure there's no other source of potassium, or they haven't been, they haven't had any sort of, you know, uh, shift in any sort of problems with their thyroid, or any other things that might um, cause their potassium levels to go up. So always go for the low hanging fruit. So if someone's on a diuretic and certainly on a beta blocker, what's the first thing? What do beta blockers do that you always have to watch out for? We talked about this a lot in Pharm 1 too. What are beta blockers known for? Hypotension, absolutely, absolutely. So orthostasis is something. If somebody's, yeah, decreased blood pressure. So particularly in the elderly, if your patient comes in and they're started on beta blockers, how are you going to assess them? What are you going to do to assess your patient? What's the number one assessment you're going to do for beta blockers? Check, absolutely. What are you going to do if it's low? Hold it, absolutely. Hold and call. Right. Hold and call. Hold and call. There you go. Remember that. If you next time you're in the hospital, you can do the hand gestures. I learned in pharmacology too. Hold and call. So anyway, it's never a bad decision to double check. And sometimes even this pharmacy will send parameters, and if it's you started your patient on beta blockers, it's their second dose, and the parameters sometimes say, like, I don't know, 100/60, but your patient is 80/40, then that's clear cut. You call the doctor, but first you hold it. Always hold it. So we talked about verapamil a little bit yesterday. For certainly, it's given for tachycardia. When DIG is being given for heart failure, always look at your patient with extra special eyes, because sometimes those two medications will affect the heart rate. Remember, um, DIG and both DIG and verapamil. We talked about verapamil yesterday. What it does is it slows or it suppresses the impulse through the AV node, right? And so certainly, if somebody is on verapamil, you're always going to have them on an EKG, but you start giving them DIG as well, digoxin as well. What that's going to do is that's going to really slow. Not only is it going to slow their heart to the ventricular response, but it's going to slow down, because sometimes you give DIG for AFib. So your atria are not firing appropriately. So then the atria, or the atrioventricular node, is not, or is the AV node is not sending the signal down to the ventricles. So what that means is you have a potential for that atrioventricular block. Those signals are being blocked. And once again, you have two bad actors. You have digoxin, right? And then you have a verapamil. Although in and of themselves, they're very beneficial. But if your patient has heart failure and you're giving these two drugs, both have the potential to suppress that AV node conduction path. Does that make sense? Does anybody? I felt like I kind of struggled through that last night, and I apologize. So I'm hoping, maybe to redeem myself here and to make it a little clearer. So does anybody have anything to add? Professor Padilla, you can jump in if you want, to bring in your wisdom as well.
Nothing to add. Yeah. I thought you covered it well yesterday too, but doing great today as well.
Oh, thank you. Thank you. Sometimes I start talking really fast, and I don't know if my mouth is moving faster than my brain or vice versa. I'm not sure my brain can move as fast as my mouth, but it would be a miracle for sure. So speaking of digoxin, why isn't digoxin the first line of treatment for heart failure? Why don't we use it as the first line treatment for heart failure. Anybody got any ideas? Too many interactions? Absolutely, absolutely. One thing digoxin does is it affects the myocytes, the cells of the heart, and it causes what is referred to as cardiac remodeling. And what that means is it means that your heart literally begins to take a different shape. And so, unfortunately, while digoxin can literally help the rate control, it doesn't actually fix anything. Okay, so other things like verapamil can actually is more of a fix on the conduction. The digoxin is more of a there's the chronotropic and the ionotropic, where one is the rate control and one is the squeeze control. So you have different pathology. One is, of course, the signaling with the electric system, and then the other is the contractility of the muscle. So digoxin, because it pays almost no attention to the effectiveness of the muscles, it eventually over time can cause remodeling of the heart itself. And it can actually, on autopsy, can look kind of odd, which is why we go to other things like Lasix and beta blockers and calcium channel blockers. And basically, more or less, beta blockers and calcium channel blockers will do the very same thing. They block or mute the overexcitability, calm down the overexcitability, which is why it's not only good for blood pressure, both of those, but also for arrhythmias. If I'm correct, if I'm saying that right. And digoxin, because it really pays no attention to the muscles of the heart, it can be known to increase the cardiac workload, and that, in order to get those ventricles to respond. And so sometimes, particularly in chronic use of digoxin, it can actually, in the long run, while it make the heart become, because it's getting it to work so hard, it just it's a negative influence on the function of the ventricles, therefore leading to a little bit of cardiac remodeling. And certainly, anytime if your patient's on Lasix, what is one thing that Lasix really does well? We talked about that a second ago. Not a second, 10 minutes. Removes fluid. But because it removes fluid so well, what are the side effects of that profound rapid fluid shift? Electrolytes, right? Hypovolemia. What happens when you have hypovolemia and you're losing your electrolytes? You get kind of what? You have an imbalance, you get kind of confused, fatigued, tired, all of those things. Absolutely, absolutely, absolutely. And then something else we talked about and somebody mentioned this earlier about your ACEs. Certainly there's a time and a place for an ACE. It's not when you're pregnant, certainly when you have diabetes, not when you have a cough. Then of course, you need to go a different direction. So, does anybody have any questions about that? Drinking hot tea. It's cold outside. Anyway, so we've got a couple of other things to go over, but we'll keep going. Is everybody okay? Alrighty. So we went over Coumadin and we went over heparin. So what if if I'm on Coumadin, what's my therapeutic range and how do I measure it? INR, absolutely. Yeah, I gotcha. 2 to 3, absolutely. So that's my range. So if I'm taking Coumadin and you're monitoring my INR, and it's low or it's lower than 2 or higher than 3, certainly you're going to contact the physician, right? Because you might need a dose adjustment for sure. So um, sometimes and I remember talking about this in class. I think Professor Padilla might have talked about this, but sometimes, or I don't know, maybe I dream about it, but sometimes when you're in the hospital, patients are started on heparin, because why are some reasons why you start your patient on heparin? It's fast acting, absolutely. AFib, clots, well, absolutely. Um, Absolutely. And certainly if your patient's gone through surgery, you might have to start them on heparin. But sometimes they're on two at the same time. They're on heparin and Coumadin. Why is that? Why would they be on heparin and Coumadin right before they go home? Absolutely. One is fast and one is long, Jasper. And then because you just can't stop the heparin and start the Coumadin, because the Coumadin takes a good bit. The half-life is long. So you take the heparin absolutely long to cover while the Coumadin is reaching therapeutic levels. Absolutely. 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 Let's see. And so I think we talked about what do you reverse Coumadin with? Your patient's got too much, your INR is extremely high. What are you going to give? Absolutely. And then what about heparin? Absolutely. Absolutely. Very good. Very good. Very good. Let's see. We talked about vitamin K, and interestingly enough, they'll give vitamin K. Will be given it to the babies in the nursery when they're born. It's called aquamaphytin. I guess they still do that. Professor Padilla, do you know?
I'm not
Oh,
sure.
that's right. They don't have. That's right. They don't have clotting factors. You're right, Tori. Wow. Y'all do have 3 tests next week, don't you? Y'all are studying. Very
They
good. Very
are.
good. They're very good. So what are low molecular weight heparins? Who's teaching you OB? Is Dr. Cook? Oh, Tori Jones. Let's see. Cook. Oh yeah, she's nice. Tell her I said hi. Has she finished her doctorate yet? I don't know. That is off topic. That won't be on your test, by the way. Um, yeah, or we could put a bonus question. Has Professor Cook finished her PhD? Um, let's see. So, what did I ask? Oh yeah, Lovenox, low molecular weight heparins, right? So how do you give those? And what's the advantage of giving low molecular weight heparins? What's the advantage of giving them? Sub Q. Yeah, but what's an advantage? Yeah, yeah, definitely give it with the bubble. Yeah, you don't have to monitor it, right? Right. No blood work. Absolutely, absolutely, absolutely. So let's see. Here we go. Um, 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 it's a nitrogen bubble. It's actually a nitrogen bubble. It's actually keeps the um, Lovenox from running away, escaping. Yeah, it's a little nitrogen bubble. Interesting, Lamp. I'm one day, when I'm just curious and have nothing to do, I'll go try to figure out why it's nitrogen, but it is nitrogen. Let's see. What are we talking about now? We talked about epinephrine for the heart, and we'll talk about that in a little bit too. But there's other reasons why we give epinephrine. What are some more reasons why we give epinephrine, and how do we give it? Anaphylaxis, absolutely. Shock, surely. Yeah, we can give it IV. We can also give it with lidocaine, absolutely, when somebody has a local procedure. I'm thinking about one more time. When else can we give it? Inhalation, absolutely. Why would we give it inhalation, Jasper? Asthma, yeah, certainly. Certainly bronchospasms. Absolutely, absolutely, absolutely. And so what happens when we're giving it for if we're giving it for asystole, right? So for asystole, we have no blood running around our veins at all, right? There's absolutely no circulation. So we're going to give it an asystole because we're hoping and praying that we're going to start the heart and it's going to keep the blood in the core. And what that means is it's the same reason why you give other things. It keeps the blood in the core, but when it keeps the blood in the core, what else is going to happen to your extremities? What's going to happen to your nose and your ears? They're going to be cold. Absolutely. You're going to get, yeah, they're going to be cool. They're going to be, you're going to have weak pulses because what's going to happen is you're wanting to keep, your body is so wonderfully made that you're going to want to keep the blood in your core. And, by the grace of God, you're going to start the heart again, right? But the main things you have to worry about are your kidneys, right, absolutely. Your brain, the epi Hail Mary, absolutely, 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 yeah, very good. You guys are so smart. Y'all have been studying a lot. Um, let's see, and what else? And so in the same, in the same vein, there's another drug called norepinephrine, and basically it's Levophed. So, have you talked about this in your med search course yet? Not much. Okay. Well, what it does, Levophed, same thing. You're going to be your patient's tanking. You're going to give them some Levophed or norepinephrine. Absolutely. You're going to give them this Levophed, and I mean it's the same story. What you want to do is raise the blood pressure. You want to keep it in the core, right? So when you're giving medications like that to control volume, you're going to always want to make sure you monitor what? What are you going to monitor to control volume? Certainly, blood pressure. Absolutely, absolutely, absolutely. And certainly you hope they're, you pray to God in heaven their kidneys are working too, right? But certainly they may come around hopefully, but again, the Hail Mary for sure. Um, let's see. We talked about diabetes type 2 and metformin. Um, let's see. What do Okay, let's see. We talked about this a hot minute ago about insulin. Um, Sometimes when your patient's in the hospital and they're taking steroids, certainly you may have to give them, if they're not diabetic, even and they're taking steroids, you might have to monitor their blood sugar and give them steroids. Um, Unfortunately, even patients who are on anything oral, even if they're on metformin and they're on steroids, is certainly going to affect their blood glucose levels. Um, uh, when your pregnant patient goes to the hospital, they can't take metformin, but they can take insulin. So a lot of times, acute care, when patients are in, certainly they're on ventilators. Anytime you're having a patient that is taking tube feedings, you're always going to monitor their blood sugars. Always, always, always. Steroids. What else? There's a couple other cases. Can't think. Professor Padilla, can you think of it? A couple of them, other situations. Steroids. Um, yep. Yeah, absolutely. You're talking about cancer. Yeah, that'll jack up your blood sugar too, for sure. For sure, for sure, for sure. Let's see. Certainly, anytime we didn't really talk about shock. Have y'all talked about shock in your med surg classes? We talked a little bit about shock, uh, not much though. If your patient comes in and um, and they have a really, really, really low blood pressure, certainly you're going to want a volume. You're going to want to increase the volume, right? But if volume doesn't work at all, then in order to raise their circulating volume, then that's when you're going to start with the norepinephrine, those sorts of things. So remember, um, as far as allowing circulating volume to remain in your system, um, the the go-to to treat shock is fluid volume resuscitation. That's your go-to. And then if that doesn't work, then you start to give them um, something that's going to keep that blood in the core. Um, I don't know if I told you, but when I was on the floor as a house supervisor, um, I had a very well seasoned nurse, and the patient was supposed to get an antibiotic, and he accidentally hung dopamine. So he was running it in at 125 an hour. So you can imagine that that patient became severely volume challenged. And so he actually coded, and we got him back. The crash team came up, or he was in the ICU. So um, anyway, they resuscitated him, and the nurse actually started the drip back over again, thinking that it was the dopamine, thinking it was the antibiotic was the dopamine, and the patient did end up dying. And I say that not to scare anybody, but he literally that night he just literally didn't pay attention. So one thing that helps, um, he made a mistake. He really did. Um, yeah, he did. I mean, it twice, not once, but twice. And we found out because anytime someone codes, the emergency room doctor, at least it used to be that way, uh, you 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 might could, you absolutely might could, you might could, but the emergency room doctor came up, and he was the one that actually figured it out. So the hospital ended up not turning him in, um, but because honestly, I mean, I probably would have let him take out my kidney, I don't know, in the break room. He was that good of a nurse, but he just what that one time you don't pay attention, certainly. But anyway, enough of that. So I talked about this earlier. Yeah, it was definitely a bad day. Definitely a bad day. So I talked about this earlier when it comes to fluid volume, and monitoring fluid volume, and shock. As soon as you start replacing volume, and I mentioned this a minute ago, but as soon as you start replacing fluid volume, certainly your blood pressure will come up, but always look for that kidney response, because, you know, when those organs start working together, then you know that the the bad day is going a better direction. So when my mom was in ICU, they had her on all of these things, but her kidneys never started working. So, and the other, once you start from the very beginning, right? You prioritize, you do your ABCs, but certainly when somebody is, you can fluid volume resuscitate them, but you have to see the benefits of it, and certainly kidney response is certainly a benefit you check for. Let's see. So there's a lot of dosage calculations. We'll talk, I think we posted, did we post something about those, Professor Padilla? I forgot. I can't remember. I teach Pharm 1 too, so.
Okay, I'm sorry. My work phone had called on while I was muted, so I think I missed the first question. But yes, I think we did post them.
Have y'all had a chance to look over those dosage cal questions?
I'm opening up another tab just to be sure we didn't miss it, but I believe we did.
Yeah, we'll recover. All right, there you go. Yeah, the heparin ones too, because you're going to give heparin. I just saw a heparin question. You're going to give heparin by week. You're going to give heparin weight based. You're going to give units per kilogram usually. That was always a lot of fun, right? Well, there's the heparin ones for sure. For sure. And then there's a couple like generic mils per hour kind of stuff.
Yeah, they were posted on January 23rd, the practice heparin questions.
Okay, good. Good. Thank you. So we'll start talking about antidysrhythmic medications. Does anybody have any questions so far? So remember, yeah, there's some infusion rates. As far as antidysrhythmic medications, certainly we talked about furosemide, we talked about sodium. It doesn't so much affect your heart rate, but other things do. Certainly digoxin has a dysrhythmic effect on the heart. Certainly potassium, right, has a dysrhythmic effect on the heart. So some of the things that you're always going to want to make sure that you do is you check their potassium. It's posted on your blackboard to make sure that that's one thing you always consider when it comes to potassium, whether it's low or high. Remember, sodium doesn't so much affect that, but potassium does. So when your patient is, I mentioned, we talked about this just a little bit ago, but anytime your patient's on Lasix and anything, your Lasix is going to wash out. So there are certain things that won't wash out with it. Certainly sodium will wash out with the water, but digoxin will not. And as a matter of fact, when you're on Lasix, you're going to decrease your volume, your serum volume, but your digoxin level is going to basically remain the same. So what that's going to cause you to do is going to cause you to always look for signs and symptoms of toxicity. Wow, toxicity, man, I made up a word. So what are your signs and symptoms of dig toxicity? Halos, there you go. Seeing angels. That's right. Absolutely. Nausea, absolutely not nausea as well. And certainly anytime you're, given something, it's going to anything that affects your electrolyte levels, anything that affects your heart rate or rhythm, you're always going to put your patient on an EKG. So we talked about also yesterday, I fumbled, let's see, when I click on the link for heparin calculations, it says not found. We'll have to double check that. Does anybody else have that trouble? All right, well, we'll have to go back and look at that. Gee, wow. With one question works. Holy moly, we'll have to fix that. So, so we talked a little bit about adenosine yesterday. What does adenosine do? What does adenosine do? What are you giving adenosine for? That's right. And so you're going to check if adenosine is working and if that PSVT is going away. So a couple of antihypertensives that we talked about that work for dysrhythmias. I just mentioned them a couple of minutes ago. What are they? Beta blockers and that's right. The blockers, absolutely. Because what you're going to do, what you're trying to do is you're trying to block the transmission of those erratic stimuli, right? So you're trying to um, mute those atypical responses. Remember, the heart does the love dub kind of thing. Atria, ventricular respond. Atria, ventricular respond. Sometimes if it's doing this, right, you're going to want to, those are called atypical foci. So you're going to want to calm those down, which is another reason why if you're on DIG and then you're also on another antiarrhythmic, you always have to watch for those AV blocks. Always pay attention to those things too. So let's see, we talked about the prodromal effects of antidysrhythmics, prorhythmic effects. Certainly, if you're trying to fix a dysrhythmia, there's always the chance that you could make it worse because they can actually exaggerate the dysrhythmia while it's trying to correct it. And it has to do with the calcium channels, and that's a way stretch for me from advanced pharmacology when I was in my master's school. But suffice it to say, that's correct. So if your patient is in SVT and they have asthma, are you going to give them a beta blocker? No, nope, absolutely not. Absolutely not. If your patient has bradycardia, what are you going to give them? What is bradycardia defined as? Atropine. What's the definition of bradycardia? Absolutely, absolutely. And if your patient is in VTAC, what's VTAC? Absolutely. They're tacking along really fast, about, I don't know, 160, 180. And they're doing pretty much, A-okay. Would you ever defibrillate a patient who's talking to you? No, absolutely not. Absolutely not. What you will do, if you don't want to get smacked, because they might reach over and pop you. Because if you defibrillate while I was talking to you, I probably would be pretty angry. My best friend's dad, and yeah, oh, he was conscious? Did they give him anything like Versad? Why'd they shock him, Tori? Yeah. Seriously? Why? They must have had a really good reason to shock him, or they really didn't like him. They shocked him with chest pain? Man, where was he? Yeah, they might have just paced him. They could have just paced him, because when you put the pads on, sometimes he went to a clinic. Oh, they could have cardioverted him too, but still, that hurts. I mean, that cardioversion is a shock. Gosh. Anyway, well, that's a whole nother rabbit trail. So I guess if somebody is an AFib, we talked about it. You can also give them lidocaine. Remember, we talked about last night about giving them some lidocaine. Lidocaine can certainly bring down the ventricular tachycardia. And one thing that why are you worried about ventricular tachycardia? What are you worried about ventricular tachycardia? What don't you want to happen? Well, and you don't want it to convert to something else. Because the worst part about ventricular tachycardia is that it can convert to ventricular fibrillation. So you want VFib, absolutely. So lidocaine is something that can slow down the heart before it gets to the next level for sure. Let's see. We talked about beta blockers and its effects on the heart. We talked about amiodarone is all. I think I mentioned this yesterday. Amiodarone is toxic to the liver. So if you're giving your patient amiodarone, you're going to watch out for what? Especially if they have liver problems. Now, liver toxicity is rare from amiodarone, but it's not rare if your patient already has hepatotoxicity issues going on. Yes, for sure. Absolutely. And and also when it comes, we talked about metoprolol a couple of 20 minutes ago, and there's a lot of things about metoprolol. Certainly, metoprolol can mask the signs of what? You're giving metoprolol. Yes, hypoglycemia for sure, indeed, for sure. Let's see. Anytime you give anything that has to do with anticoagulation, you always check for bleeding gums. You always check for blood in the stool. You always check for blood in the urine. Always make sure, even aspirin. If you're giving aspirin, you always check for those sorts of things for sure. Let's see. We talked about antihistamines. Does anybody remember when we were talking about, I think Professor Padilla, you gave the lecture on antihistamines. So there's a couple of those that work better than others, like Allegra. Some, like I said, some work better than others. There's one particular drug that's called fexofenadine, and it's actually post on Blackboard. I'm going to see it shared in the PDF chat. Let me see. Is it there? I didn't see it. Huh. Yeah, I don't see it in the chat.
Sorry, I was still on mute. So it allows you to share files. So do you all see the square with the arrow pointing to the right? Maybe because I'm not a moderator. It's not letting you all access. Somebody else was able to access it though.
I think everybody should be moderators. Sorry about that.
Or
I hope
maybe
there's nothing I can do.
there's
I
nothing.
did.
Can you see it there? If you go to share content, are you able to? So, okay. Well, it is posted in Blackboard. I just added it, so you should be able to access it that way as well.
So a lot of these antihistamines are good. Some are better than others. Some have fewer side effects. Um, Fexofenadine is one of those that do have fewer side effects. Certainly, it allows you to enjoy most of the other things in life. I don't know, an occasional glass of wine. Usually, alcohol is not recommended for um, any particular any drugs at all, actually. But this one, for whatever reason, is kind of uh, an exception to that rule. So let's see, prednisone is there's several drugs we've talked about, or we will continue to talk about, that you must keep taking. Prednisone is one of those drugs. Do y'all know what a steroid dose pack is? It's like a tapered drug. It's a tapered a dose. You take 9, then you take 8, then you take 7, then you take 6. But you never stop steroids cold turkey. You never stop, anti-seizure medications cold turkey. You don't stop taking benzodiazepine uh, cold turkey, and steroids are no different for sure. Let's see. We talked about urokinase, ataplase, and streptokinase. Does anybody remember what I said about ataplase? And we're talking about, we're talking about when someone has been either diagnosed with an MI, usually blood clots, absolutely. Usually ataplase is very specific to MIs, and you have a certain window of opportunity when your patient comes in the ER um, with chest pain, to where you have, is it, Professor Padilla, is it 15 minutes for you to get EKG?
Yes, I believe so.
Yeah. Anyway, so you have a very narrow window of opportunity, and certainly you can, if the EKG shows evolving MI, the first thing you're going to do is you're definitely going to, before you cart them off to the cath lab, definitely you're going to give them probably ataplase, certainly a clot buster. And then there's urokinase and streptokinase. Certainly those work as well. But one of them is very specific to pulmonary embolism because it works faster. Does anybody remember which one that one is? Well, certainly you guys can look back through your notes and find that one. So make sure you pay attention to the differences between streptokinase and urokinase. Um, let's see, we talked about glucocorticoids. What do they do? This is just kind of random. We talked actually in Pharm 1, we talked a lot about steroids and glucocorticoids. What do they do? What is the side effect? What are some of the side effects? Why do you give a immunosuppressants? Absolutely, and that's a lot of reason why you give them. Certainly, you can get a steroid shot in your shoulder. Certainly, what does it do? It decreases inflammation. What is inflammation? It's a response. Treats inflammation, absolutely. And how does it treat inflammation? It suppresses the immune system. So remember those sorts of things. Steroids, certainly raise your blood sugar, certainly uh, interfere with Coumadin, like just about many other things. And then let's see what else. Um, a lot of times, we talked about Coumadin. Coumadin for AFib, it's one of those insidious things. It doesn't necessarily, particularly in the older population, you want to be careful with heparin. But a lot of times AFib is discovered later in life when your patient just incidentally goes in for a checkup. And so it's not unusual to just to drop a little, for the provider to drop a little bit of Coumadin, uh, a low dose Coumadin. That's usually kind of the go-to, but you know, 9 times out of 10, they definitely won't um, use heparin, especially, if it's asymptomatic. A lot of times, chronic AFib, they've just lived with this chronicity of the little fibrillation of the heart. And when it's discovered incidentally, then a little Coumadin certainly can help correct it, particularly if they're not necessarily symptomatic, for sure. So I mentioned this earlier, prednisone. Um, what adverse effects will we see from prednisone? Certainly, we talked about causes blood sugar, right? What else? What else can prednisone do? Especially IV prednisone, methylprednisone. Yep, it absolutely does cause weight gain. It can cause spontaneous. Oh, yeah, because it leaches calcium out of the blood. I mean, out of the bones. You can get infections, right? And certainly anybody with active bleeding is not going to get a steroid either. Let's see, heart failure. We talked about that. calcium channel blockers, beta blockers, and diuretics. Um, Certainly, calcium channel blockers affect the renin, the RAS system. So anything that affects the RAS system as well um, can also treat heart failure. Let's see. We talked about hyperkalemia. We talked about the things that reverse it. Somebody mentioned this earlier when we were talking about it, that it's not unusual to give insulin with glucose, because what you're trying to do is you're trying to force the potassium back in the cells. So if what the insulin does is it allows the glucose, it forces the glucose back into the cells, and it forces the potassium out. So you see that shift, and it definitely also helps with hyperkalemia as well. And that's, of course, why if anybody is in ketoacidosis, that's what they will give them as well, because it does take the potassium and force it into the cells to take care of that as well. We talked about what you do for anticoagulant therapy. What is patient teaching for anticoagulant therapy? Soft brush, straight, no razors. Look for bleeding. Yeah, absolutely. And sometimes you even throw a medic alert bracelet on. Absolutely. There you go. There you go. Yay, yay. Thanks, Professor Padilla. And then we talked about digoxin. Um, Certainly toxic levels will give you an irregular heartbeat, make you nauseated, make you vomit. Everything makes you nauseated and vomit. The cold weather makes me nauseated. It's too cold for me. I'm not a penguin. Does anybody have any questions? Professor, 75 or 74? Professor Padilla, do you remember?
I'm verifying now. I think it's actually 74. I think you're right. 74, and then I think we're just finalizing the instructions for Tuesday. We'll put an announcement in Blackboard when the exam is ready to download.
Yeah.
We're just going to confirm what the password release is going to look like, because when we used to proctor the exams, we would post it under the Blackboard announcements 15 minutes before exam time. So we're not sure if we're going to be doing that or if the proctor is going to do that. So as soon as we know those little details, we'll make sure we post it for you all.
Yeah, we'll let you know. I'm certainly not in the know, and so as soon as somebody in the know tells us, then we'll be in the know and we'll tell you, because that's how it rolls. When we're in the know, we give you the know, and then you have the know, and you're all in the know with us. You know? All righty. Does anybody have any questions? Complaints? Comment? What do you use to scrape the ice off the cars? Hot water doesn't really work that well, right? There's something else that works. Alcohol? Credit card. I need a credit card. Can y'all send me your? I'm kidding. Just kidding. Hot water will crack your window. Absolutely. 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 I don't know. Put a blanket over it before it freezes. I have done that, and then the blanket froze to the car. Car scrapers. Room temperature water. Start your car and let it run 30 minutes, man. I did that one time. I ran out of gas. Of course, it was a long time ago. I was actually in nursing school. Oh, those good memories of nursing school. Where's Jasper? Where are you, Jasper? I know you're there.
I said the prayer yesterday.
Well, it's not 24 hours later. Just kidding.
Let me Google something real quick.
Let's, oh yeah, black ice, Tori. Yeah, absolutely. I mean, it looks like it's wet, but it's like a solid sheet of ice. You're right. Yeah, everybody be safe. Yeah, for sure.
I
Okay,
think
I
I
think I
have an
found one.
exam prayer. Oh, did you find one, Jasper?
Or no, you could say one if you want.
All right, I have one for exams.
Oh, heck yeah.
Lord, as I take this exam, I take comfort knowing that my value is not based on my performance, but on your great love for me. Come into my heart so that we can walk through this time together. Help me not only with this test, but the many tests of life that are sure to come my way. As I take this exam, bring to my mind a calm focus. Help me to remain confident in my ability and firm in the knowledge that no matter what happens today, you will always be with me. Amen. And I'll post this. I like to post this on Blackboard before our exams too, but I know you all are going to do fabulous.
Absolutely. Absolutely. Good luck, everyone. Be sure and listen to the recording again. I would strongly encourage it. If you have any questions, reach out to us, please. We're certainly here to be your support system. Answer your questions. Be available for your concerns. I guess that's all I have. Does anybody have anything else?